I had Kinley in the morning, and that following night, like overnight, I was questioning the nurse on her breathing pattern. And then in the following morning, when the pediatrician does the rounds, the OB nurse had put a pulse ox on all 4 of her limbs, and there was all 4 different numbers. So that's when she called the doctor back and said, something's going on here, and he did not hesitate. He instantly arranged for the transfer to Peoria.
Kinley has a condition called interrupted aortic arch. And so the major blood vessel that takes blood to her body actually was interrupted. There's a normal blood vessel that all fetuses and all newborn babies have called a ductus arteriosus. And usually within the first few days of life, that extra blood vessel closes. Babies don't usually need it. But when that closes in someone with an interrupted aortic arch, the blood flow to the lower body goes away. And that's what happened to Kinley. The ductus arteriosus started to close. She started to get sick. And so an echocardiogram was performed, the diagnosis was made, and she was transferred to the Children's Hospital. I was the cardiologist who was on service when Kinley was transferred to the Children's Hospital. We were able to give her a medicine to open that ductus arteriosus up, allowing her to get blood flow to the lower body until our surgeons were able to come and do a surgical repair.
I couldn't go because I had a C-section, so I was stuck back in Bloomington. I didn't fully understand it all. In the beginning, with us being in 2 different hospitals, it was hard for me to communicate with the doctors over in Peoria. I was terrified. I mean, I didn't think she would live. I had the pediatrician in my room kind of explaining as much as he knew about it, but I still couldn't get to her. I couldn't see her, and I couldn't see the doctors and talk to the doctors. And so to me, it just meant that she wasn't going to survive. That was my initial thought. When I was able to go back to Peoria and see her, they pretty much had her on a paralytic, trying to stabilize her to get her to the next stage, which would have been her full open heart surgery.
That procedure was then to try to correct the defects completely. There was still some uncertainty, or even guesswork, if you will, as to the 3-dimensional relationships of anatomic structures inside the heart in some of these defects. What the virtual reality and the 3-dimensional modeling has allowed us to do is to, with amazing accuracy, define that anatomy well prior to the operation.
Since 2012 and 2013, we've been 3D printing exact replicas of patients' hearts. And these exact replicas, as we print them, actually allow us to look into the patient's heart before going to surgery. While we have support to do that here at the Children's Hospital of Illinois, we actually want to try to make a sustainable model. And so the very first step that we took was, can we still achieve that same level of understanding, that improved understanding around the 3D model, and move from the physical world into the virtual world? And so as of about 12 months ago, we started putting the hearts in virtual reality instead of physically 3D printing the hearts.
The virtual reality has taken this all a step further in the sense that you can actually enlarge the heart size of this room. I can actually walk inside the heart and look around and define all of the relationships inside the heart with great accuracy, and actually plan a surgical operation based on what I'm seeing at that sort of magnified level.
This was all new, like the 3D mapping was new to us at the time. So he explained to us that it would be a 3D image so they could really look at her heart as a whole and determine what would be the best for her. I think first of all, it's way over my head, but it's fantastic that we have that capability now. I mean, it's mind-boggling that they can do that.
I want to see more investment in this type of technology, this type of imaging, and this type of research, and more dissemination of it throughout the world. The AHA, of course, has a tremendous profile which would give us an enormous amount of support and exposure to facilitate these ideas, no question.
With the money that the AHA is applying towards congenital heart disease, my hope is that as we demonstrate little chunks of value of translating these 2D images into the 3D models, that we're going to be able to expand on that value and begin to quantify it. And so the funding that can occur through the AHA research really allows us to accelerate that by really focusing on things that are impacting patients today.
In 1950, 50% of kids who were born with congenital heart defect died before they made it to adulthood. Nowadays, almost 95% of kids who are born with congenital heart disease will live to be adults. On top of it, congenital heart disease is the most common birth defect that we see in the United States. Approximately 1% of children who are born will have a congenital heart defect. Fortunately, not all of those will need open heart surgery like Kinley, but many of those kids will need long-term follow-up as well.
It was difficult, of course, seeing her like that, but it was comforting because I had complete confidence in the care in the NICU and at Children's Hospital. I trusted them, and I knew that they were doing all that they could and giving her the best care that she could have.
One of the big reasons that I like doing my job, congenital cardiology, is because I get to see children who are born grow and progress. And I saw Kinley struggle after her initial surgery. I saw her very sick when she was first transferred to our hospital. And today I get to see her walk into our clinic with a smile on her face. The Ray family can certainly say that they can give hope to other families who are going through it. Each day is a slow victory for them. And I think that is fulfilling for me, and it's a big reason why I do this.